Hello, good afternoon and welcome. I'm Dr. Leonie Craig and I'm a public health nutritionist and lecturer in applied health sciences here at the University of Aberdeen. I'm lead for our MSc in Applied Health Sciences programme, and also I lead some of our core public health and global health courses here at the university. I'm going to be your chair this afternoon for this session on the key underlying important public health concepts of social determinants of health and health equity. And I'm joined today by 4 colleagues from the university, our local health board, and our local authority who are going to be talking to you today a bit about their work and expertise related to this topic. Please remember that you can type any questions that you have as we go along in the Q&A, and we'll address these once our speakers have finished. Here at the University of Aberdeen, we have a long-standing strength in teaching and research in public and global health and applied health sciences. We scored first in Scotland and 8th in the UK in the 2021 Research Excellence Framework in Public Health, Health Services and Primary Care. And we are home to one of the UK's leading medical schools and applied health and nutrition research units, conducting interdisciplinary research to explore practical health solutions. The topics being discussed today underpin our teaching and research, with our Masters in Public Health, our MSc in Global Health and Management, our MSc in Applied Health Sciences, as well as other key public health related degrees in health psychology, health data science, health economics, research methods for health and nutrition. So before I bring in our speakers, for those of you who may not be familiar with these terms that we're going to be discussing today, I'll just start by giving a brief definition of these topics. So the WHO describes the social determinants of health as the non-medical factors that influence health outcomes. So these are the conditions in which people are born, grow, work, live and age, and the wider set of forces and systems shaping the conditions of daily life. These include economic policies, systems, and social norms. And these can have an important influence on health equity or inequity. So this is the unfair and avoidable differences in health status seen within and between countries. So addressing social determinants of health appropriately is fundamental for improving health and reducing health inequities. And this requires action by all sectors of society. So now I'm going to introduce to you our 4 speakers for today, who are going to touch, as say, on their work in these particular areas. So firstly, I'm really pleased to be introducing Professor Shantini Paranjyothi, who is the Deputy Director of Public Health for our local health board, NHS Grampian. Shantini.
Great. Thanks, Leonie. So hello, I'm Shantini Paranjyothi, Deputy Director of Public Health at NHS Grampian. So NHS Grampian is one of 14 health boards in Scotland, and we serve a population of about 580,000 people. The health board is responsible for the protection and improvement of the population's health and for the delivery of frontline healthcare services. So I'm going to start by telling you a bit about myself and how I came into public health. I'm a medical doctor by background, and early on in my career, I worked in obstetrics and gynecology and sexual health, and became really interested in evidence-based medicine and how we use data to understand what works, to generate evidence to guide our practice, and how we then translate that evidence into policy and practice. So I took some time out to do a master's in medical statistics and then went on to do a PhD in epidemiology. My doctoral thesis was on exploring the variation in cesarean section rates across maternity units in the UK, and that made me really interested in health inequalities, particularly why health outcomes vary for different groups of women and children, depending on their social and economic characteristics. So I went on to do specialist training in public health medicine in Cardiff in Wales. And when I finished training, I started working as a clinical senior lecturer in public health medicine at Cardiff University. And there I built up my research portfolio on health inequalities in women and children. Most of my research was based on epidemiological analyses of large record-linked data sets of routinely available health and care data. And really what I was doing was exploring the relationships between social, economic, and environmental factors and health outcomes for women and children. And after a while, I became a professor of preventative medicine in 2016. In 2020, I moved to Aberdeen as Professor of Public Health and started in my current role as Deputy Director of Public Health in February 2023. So, Leonie, I'm going to ask you to share my slide now. And I've put the slide up really to give you a bit of a flavour of the type of work I do now, still very much focused on inequalities. So this slide shows the trend in premature mortality in Scotland. Premature mortality rates were declining in the first decade of this century, but then started to stall around 2014, well before the pandemic, and we're now seeing an increase in these rates. The rate of this increase is greatest in our most vulnerable communities, and we are seeing a widening in the inequality gap between the least and the most deprived areas. This pattern is also what we see in Grampian, our health board area, and there are also inequalities within that. So men in the most deprived cities of Aberdeen City die 10 years earlier than their peers in the least deprived areas of the city. For women, this difference is about 8 years. Every year, we publish a Director of Public Health annual report, and last year we outlined 4 threats to population health, and I think these will resonate with you wherever you are. So these are the rising cost of living, threat from infectious diseases, the increasing demand for health and care services, and climate change. So there's a little figure of a man on one side of the slide, and we refer to this as the Marmot Man. We know that how we live, our social and economic circumstances, and where we live and our environment accounts for more than half of the health inequalities that we see. Access to health and care services is important, but that accounts for only about 20% of the variation that we see. So we have to coordinate our efforts well to address these wider determinants of health, to tackle health inequalities, and address and mitigate the impacts of the 4 threats to public health that I've just mentioned. In Grampian, we've got really strong commitment from partners across academia and public sector to take a population-based approach to address these challenges. So in my current role based in the NHS, I work with colleagues at each of the 3 local authorities across Grampian and with the University of Aberdeen to coordinate our activity to improve our population's health. I also contribute to teaching on the Public Health in Action course and supervising research projects or work-based placements. At the top of this slide, I put Acheson's definition of public health, and I've reflected a bit on this, and I think I started off in my career working on the science part of this definition, and now my focus is very much on the application of this through working in partnership with different organisations across the system. What we bring to the table in public health is the expertise around the evidence base, what this means for local populations, evaluating what we do so that we're consistently learning from what we do, and supporting the coordination of the collective activity across the system so that together we can work effectively with our communities and create the conditions where people can live healthy, fulfilled lives. I guess it's back to you, Leonie. Yeah.
Thank you very much, Shantini, for that great overview of the areas that you work in related to this. Now we're going to hear from Dr. Sarah McGarrell, who is a Senior Research Fellow for the NIHR-funded Health Determinants Research Collaboration in Aberdeen.
Thank you, Leonie. I'm wondering if you could put my slide up, please, if you don't mind. Good afternoon, everyone. Thank you very much. I'm going to give you a little bit of background and outline my research interests before discussing my current role. I have an academic training in psychology, followed by a master's in applied social research. And after teaching English as a foreign language in Central Europe, and after a series of fixed-term research roles, I returned to academia to read for a PhD in human geography at the University of St Andrews at the ripe old age of 30. And that was only last week, obviously. I have most definitely taken the scenic route throughout my research career. But my main research interests are in health inequalities, and I'd describe myself as a social scientist with a particular interest in social and geographical inequalities in health, namely how living in contrasting socioeconomic places can shape and influence individual health experiences, behaviours and practices. I've used a variety of methods in my research to date, but I have particular expertise in qualitative methods and analysis gained through the interdisciplinary, policy-relevant and applied social and public health research projects I've been involved in. I've worked with a variety of stakeholders, and I've applied my research expertise and experience to academic teaching and research supervision in geography and also public health. Currently, I'm a Senior Research Fellow at the Health Determinants Research Collaboration, Aberdeen, or HDRCA for short. This is one of the first wave of 10 health determinant research collaborations funded by the National Institute of Health and Care Research in 2022, and the first in Scotland. We are funded until 2027. And the HDRCA is led and hosted at Aberdeen City Council. We work in collaboration with the University of Aberdeen, Robert Gordon University and NHS partners, together with public partners. We have a focus on the social determinants or wider determinants of health. Local authorities have a central role in tackling the causes of health inequalities, and many of the functions, powers and duties that local authorities have responsibility for shapes and influences the conditions in which people born, grow, work, live and age. For example, education, place planning, the environment, licensing and housing, to name a few. So we are well placed to conduct research at improving the quality of people's life and their health outcomes through the lens on these causes of the causes. And we're doing this in a number of ways, through developing capacity, fostering and establishing relationships within and beyond Aberdeen City Council, our local university and health boards, but importantly too with communities across Aberdeen. Examples of some of the collaborative evidence and research work we've conducted to date includes household food insecurity, where we've produced evidence reviews, scoping and mapping local practice and service use, asylum seekers' health and social care needs. We've conducted evidence syntheses, and we've shared this evidence with local colleagues to inform service developments. Early learning and childcare, and we're supporting the design of a longitudinal study as well as a consultation. Collaborative research bids, working with University of Aberdeen colleagues and Aberdeen City Council staff to develop and design research on environmental and health impacts of green and blue spaces. And we're conducting lived experience projects, working closely with members of the community and service users to better understand their engagement with services. And these insights can be used for future service improvements such as community building and planning and in developing Aberdeen City Council strategies. The Health Determinants Research Collaboration Aberdeen is establishing itself as a place for positive and productive collaboration in Aberdeen and beyond, a place where there are opportunities to get involved in the work we do. We're in the process of developing further prospects for University of Aberdeen students to work on applied projects with our council colleagues and ourselves at the HDRCA. So please check out our website for more information about the HDRCA and ways to get in touch with us. There's some details at the bottom of the slide there. Thank you very much. Back to you, Leonie.
Thank you very much, Sarah. And I must apologise. I had a couple of technical issues there with your slide, but we did get it up there in the end. So apologies for that, everybody. I just wanted to remind you before we move on to our next speaker to please post any questions you may have in the Q&A, and we will address these after all our speakers have spoken. So I'm going to pass over now to Dr. Catherine Martin, who is a senior lecturer here at the University in the School of Medicine, Medical Sciences and Nutrition, and one of the leads for our Masters in Public Health on-campus programme. Catherine, over to you.
Thanks so much for that, Leonie. I just want to say I'm very pleased to be here with you all today from a very sunny, but also a little snowy Aberdeen. So a little bit about me. Well, I have been long interested in the complex interplay between the social, economic, environmental factors that contribute to both individual and population level health outcomes. And since my time as an undergraduate studying sociology and gerontology, I've been very interested in the role that individual perception, social support, socioeconomic status and occupation, community resources, and the physical environment have on health. Particularly among older adults and those with arthritis and musculoskeletal conditions. My studies during my Master's of Public Health at Yale University were in chronic disease epidemiology, and I did my PhD at the University of North Carolina, Chapel Hill, and that work was on the influence of community socioeconomic status on North Carolinians' health-related quality of life. But as I moved forward, I was really interested in life course epidemiology and focused on this during my postdoctoral training, uncovering how early life experiences and opportunities contribute to health inequalities. More recently, my research has also focused on the role that physical activity plays in physical and mental health and well-being, and a large part of my research is on chronic pain that comes with those people living with arthritis and musculoskeletal conditions, and trying to understand the varied lived experiences, different methods of assessment and barriers to health services in this population. So in my research, I use quantitative, qualitative, and mixed methods. However, I'm also exploring ways we can address social inequities and better understand the lived experience of people using creative methods. And so on the slide here are just a few photographs from a program that we ran at the Aberdeen Art Gallery called Expressions of Pain. This is part of a pain storm consortium that I am involved with, and that has a focus on neuropathic pain. So in a different part of my role here at the university, I'm also academic lead for patient and public involvement and research for the School of Medicine, Medical Sciences, and Nutrition. Some of you may already be aware of this concept where we engage members of the public or people with a lived experience of a disease or a lived experience of a social condition to better understand what research is in terms of a priority to them, and then get them involved in all stages of the research cycle, which is shown here on the slide. Such partners offer invaluable and unique insights, which help to improve quality, relevance, and impact of research. And this really ensures that research is culturally sensitive and relevant, especially to those non-majority populations. But involvement in research can also pose many barriers, especially for people from marginalized communities whose voices typically go unheard. So within Aberdeen, we have a big culture of trying to work with others across the city, from the city council, local authority, NHS Grampian, Robert Gordon University, to name a few. We also work very closely with community organizations, so we have these really strong links. And all of this is really trying to improve and enhance diversity, inclusivity, and just that accessibility of getting members of the public, people with lived experience in research, specifically within the Grampian region of Scotland. So I'm really pleased to be able to draw on my background, sort of multidisciplinary nature, whilst I mentor and guide talented students from across the globe in my role as Master of Public Health program. I am the lead for the September Start students. So if you're interested in studying with us for your MPH, please also know that we have not only that September Start, but we have a January intake, we have an online program, and we have a program at our Qatar campus. So we're looking forward to hearing from you. Thank you so much. Back to you, Leonie.
Thank you very much, Catherine. And so now I'm going to pass over to our final speaker, Dr. Aravinda Guntapalli, who is Senior Lecturer, again, within our School of Medicine, Medical Sciences and Nutrition, and is a lead for our MSc in Global Health and Management programme. So over to you,
Thanks, Leonie.
Aravinda.
Yeah, you can share my slides. Hi, everyone. My name is Aravinda Guntapalli, and I focus on health inequalities across the life course. My research is very interdisciplinary, and I started with genetics, medicinal zoology, and chemistry. And then I wanted to learn more about health settings in rural and poorer areas. So went and studied anthropology for my master's. And then I wanted to learn a little bit more quantitative methods and did another master's in population health, and then moved to Tübingen University to do PhD in economics, focusing on health and economics related interconnection. What they didn't have at that point was global health degree. If they had a global health MSc or global public health kind of MSc degree, I would have done that. So I'm glad I'm leading a global public health kind of program at Aberdeen University. My work focuses on health inequalities with the intersectionality in relation to rurality, low-income settings, lots of challenges in terms of the lack of policies of disease conditions, and across different parts of the world. So some of my work is focusing on the UK, for example. I look at food and fuel poverty in the UK or excess mortality. But in Uganda, I particularly focus on diabetes in rural Uganda with colleagues. So I put the co-author's name because this work is carried out as a team with Silva Bahendeka, who is the top endocrinologist in Uganda, and Venceslas Segua. So what today I will present is some of the things we have done, just to give you a taster of some of the research, global health research we carry out in Aberdeen. Next slide, please, Leonie. So what you see here is an image at a level 3 hospital in Uganda. So these are all waiting on a Tuesday for diabetes clinic. So every day will be a different type of NCD or a communicable disease day. So there is a particular day for diabetes patients. So you can see majority of them are women waiting because there is a stigma for men to use openly public health facilities if they are diabetic. So what you see is that people with diabetes often in public health system are women, especially aged 50 and above. So you can see there is a little registry being maintained because majority of people have to pay out of pocket. So the government only covers 20% of diabetes care in the country, and the rest of the 80% comes from out-of-pocket expenditure. So different cooperatives are collecting money and pooling money. They maintain a registry and take money so that they can buy bulk medication within those settings so that the remaining 80% burden could be reduced in a cooperative manner. Can you click on the animation, Leonie? Yeah. So what we have done is to first look at some of the challenges we have. So the first challenge we have is in a low income setting. So Uganda is a low income country and has very substantial underfunding of health systems. So within diabetes, it's already 20%, but there are other challenges and several people that are not even diagnosed as well. So this puts a lot of burden both on mortality as well as various other disease burden as well. So we realized that there was never an incidence study of diabetes in Uganda. So what we have done is we could not really get a lot of funding. This was during the COVID-19 pandemic. So we tried to collect electronic registry from 40 public health facilities and looked at new diabetes kind of cases and created a registry. And we showed that diabetes increased significantly by 16% during the COVID-19 pandemic in rural settings. So we are not only the first to create incidents, but in rural settings, normally in low and middle income settings, you never have these databases that show every year new incidents of disease occurrence for any complex condition. So we are the first to we just literally finished a couple of weeks ago our analysis and the paper and showed that it increased by 16%. Next, please. And we also had other kind of challenge in the way that the prevalence of diabetes during the COVID-19 pandemic was not available. So as I said in this picture, as you can see, this is a level 3 health system. So people living in villages at level 1 and level 2 would not be able to have any screening, any test done because such clinics are not available. So people in rural settings have to go 5 to 15 kilometers to access a level 3 kind of health system. So what we have done also to strengthen the primary health setting is in 40 villages, we have taken community health worker support, 1 male and 1 female. So with 80 community health workers in 40 villages, we were able to cover the whole village, like 40 of them, and calculate the prevalence of diabetes during the pandemic time. We were not only keen on calculating the prevalence of diabetes, we wanted to know how many people were undiagnosed previously, and we could diagnose them at these lower settings. And we could see that 11.3% was the prevalence in these 3 districts, 40 villages we have covered. And we showed that 36% of these cases were previously not diagnosed. So we were able to then show some of these challenges, that we do not need to burden the health system, but use community health workers and village health teams who are not really nurses or health professionals, but can use their support in reducing the disease burden. So these are the kinds of things, just a taster to show some of the things we have done in different settings. So look forward to your questions. Thank you.
Thank you, Aravinda, and thank you to all four of our speakers there. Now we're going to pass on to your questions that you have been posting, and please continue to post any questions you do have for our speakers. Hopefully you've had a good flavour of the types of research and teaching that we're doing, both locally and internationally relevant. So I'm going to just go through the questions that we've had posted here. And the first question is, what are the most significant social determinants currently impacting public health in Aberdeen, and how does this compare to other parts of Scotland or the UK? Shantini, I wondered if this was a question that you could address yourself, or Sarah maybe.
Okay, happy to get started, and then Sarah can chip in. So I think so what are the most important social determinants? So I guess in Aberdeen, what we're seeing is the proportion of older people is increasing. So, you know, if you look at our population structure, and projections, then, you know, the proportion of people that we've got in the older age groups is increasing. So that means we've got an aging population, and we have to think about how we deliver services then that, you know, would meet their needs. On top of that, we've got, you know, like everywhere else, we've got a rising cost of living, and that will impact on people disproportionately, depending on where they live and what resilience they have, and, you know, what their circumstances are. And in Aberdeen, just like in everywhere else, it is affecting some communities more than others. And so we are seeing issues around food security, fuel poverty, in particular so not just Aberdeen, but, you know, in the more across Grampian, where we've got pockets of more rural areas. You know, communities can be quite isolated and will, you know, suffer the impacts of this quite a lot. I guess the other thing about Aberdeen as well is, you know, with the transition away from oil and gas, there's been a change in the economic circumstances for a lot of for the city, a lot of communities around the city. And that then, you know, again, impacts on all the things, the building blocks for a good, healthy life, really. So in terms of income and secure, safe housing, and therefore then all the other things that that leads on to. So I'll stop there, and Sarah, you might want to come in and add to that.
I think you've given a good account there, Shantini. I suppose I was just thinking about Aberdeen in relation to the rest of Scotland. The question was mentioning that too. And I mean, health inequalities are writ large everywhere, I suppose. But I think working in Aberdeen in the context here is interesting with this transition that Shantini was mentioning, that there's a bit of a refocus, if you like, on some of the health inequalities in this part of the country. And they're slightly different. They operate differently to some extent than perhaps the focus that was often in the west coast of Scotland. So it's interesting working here because there are pockets of inequality everywhere. But the reasons for that are different here because of some of that economic profile, some of that, the demographic changes that are occurring here. So it is interesting to be working here in the northeast of Scotland, especially if you've had a background in looking at health inequalities. And for me anyway, geographical health inequalities are interesting, and what leads to that. The context is really quite important. So, but I would just concur with Shantini. She's given a great flavour of the main aspects there recently in Aberdeen anyway.
Thank you both very much for addressing those questions. I think I'll move on to the next question, which is thinking about the role of health equity or inequity, and the social determinants of health. What aspect of your work aims to address these? So I'll maybe sort of stick with the two of you who are on screen currently, and then I'll move to Catherine and Aravinda as well to address that question.
Do you want me to go first, Nearly? Okay.
Yes.
I think I'll draw on one area of my work, and I'm also the public health consultant lead for cervical screening, and one of the things we're looking at is how we reduce inequalities in cervical screening uptake across Grampian. So this is an area where actually this is a good example of where we worked really closely with the University of Aberdeen. We worked with the team there who undertook some evidence reviews where we looked at some of the barriers to cervical screening uptake. And based on that information, we then worked with some of our community groups, so with the Grampian Race Equality Commission, to do some focus groups with those areas where we knew uptake is quite low. And in Aberdeen City, we particularly focused on our Black African and Polish communities. So we've been doing quite a bit of work with them to really understand, what are the barriers that they see to participating in cervical screening programs? And what they've told us is really quite interesting. There's something about how we do our messaging, in the letters that we send out. It doesn't quite land so well with some communities. And also there's something about, how we provide health services here that's not necessarily understood by different communities, particularly if they've come from other places where health services are provided in a different way. So that was quite interesting actually, because it's told us a lot about where we need to focus, on how we communicate with our communities, and also, the type of information and support that we need to put in place so to gain that better engagement and informed consent for participating in some of our screening programs. So I hope that gives you a bit of a practical example for the type of work that we're doing.
Thank you, Shantini. And Sarah, what about yourself? How do you think your work addresses these issues?
I think it tries to. I think the Health Determinants Research Collaboration, which is how, we're hosted at Aberdeen City Council, so a lot of the work has been working with council officers, people who are delivering service, or service managers that are responsible for services. And we've done a number of bits of work, particularly I'll maybe use an example of public consultations. So Aberdeen City Council, like a lot of local authorities, consults routinely with its citizens on a vast variety of topic areas. And for instance, last year, there was what's called the LOIP, the Local Outcome Improvement Plan. And this is an opportunity for people out there, if you like, to say what they want to see happening in their local community. And it uses a tool called the Place Standard tool. So it's aspects of the city that, for instance, green spaces or transport, public buildings, use of spaces, for instance, things like that that people would be asked to give their views on. And usually these consultations, there's a lot of information, but maybe this information is not quite as used as fully as it could be, say. So for instance, as part of my role in the local authority, I was tasked with analysing some of these qualitative responses to try to make more of that evidence, to really kind of gather in impressions from the public on things that are important to them, and make sure that evidence was used better perhaps than it had been maybe used before. And actually it's been quite instructive. It's been used in a lot of meetings, a lot of stakeholder engagement sessions, and it's the approach to kind of making sure that that information is used a bit more is now being adopted across other strategy areas in the council. So it may not sound glamorous, but it's actually using all available evidence in a much better way, and that can be fed back to the community to say, well, actually, this is what we've done. We've used this. We've applied this appropriately. And aligned to that, we're trying a lot more qualitative work now. There's lived experience projects that I mentioned before, are trying to target, not target, but trying to engage people from harder to reach groups, people who probably wouldn't fill in a consultation, for example. So using different means and methods to try to find what their experiences are and to gather their insights and to make sure that we really are listening to people better and hopefully being able to deliver and develop services that are aligned to what they actually need rather than what we think that they need.
Thank you, Sarah. Catherine, would you like to address this question next?
Yes, absolutely. I was trying to think of like, oh, okay, what study should I mention here? So I'm currently involved in a Chief Scientist Office funded project called Sea Picture, which is it's being led out of Dundee, I should say, by Professor Leslie Colvin. And so this work is to try and understand how we can use routinely collected data to identify people with chronic pain from primary care health electronic records. And what's nice about this project is that we're going to be triangulating some data points. So not only using that routinely collected data, but to go and actually do a survey among the GP practices that are taking part in this work, but also doing some qualitative work as well. And so we want to see places where the algorithm is picking up individuals who have chronic pain, either from prescription data or consultation, and as well as where maybe they're not being picked up, but people are reporting in a survey that they have chronic pain. And so it's going to be really important to understand this, because oftentimes, and we hear this from the patient partners that we work with, is that people will sometimes fall out of help-seeking behavior. And so if they are not getting the help that they need, they might stop going back because they feel as if there's a nuisance. And there is also the stigma around chronic pain and maybe seeking prescription medications for pain management. And on the advice of our patient partners, what we have decided to add in as an extra element in this is to try and really reach out to individuals who might actually not be seeking help from the primary care. So people who may not be housed, so the homeless, and people who are maybe of a lower socioeconomic status. So we're really going to be looking at the individuals who have taken part in the research, especially with the survey, and then going out and saying, okay, who haven't we heard from? Because those are the people that we actually need to speak with. Because if you're starting to plan for resources or plan services based on routinely collected data, which hopefully with increased AI and the way that we approach big data sets, we might be able to do more of this. But if the people that we need to be focusing on aren't in that data set, then we can actually appropriately design services for them within the NHS. So I think that's one of the ways that we're trying to handle and look at some of those social determinants of health in this context. So thank you.
Thank you, Catherine. And Aravinda, what about yourself?
Yeah, I'll stick to the Uganda example because then I can bring the narrative as well. So as I've said, our focus exclusively on low income settings, as well as people that are living in rural areas with low income settings. So if we think of the statistics in Uganda, based on different types of estimates, 35% to 50% of people are classified as poor in rural Uganda. So if they need to carry the diabetes medication, because only 20% is covered by the government, if you split the remaining 80%, 6 months of the salary of this each individual has to be provided just for diabetes care and medication. And majority of the people are also undiagnosed because there is nothing at the primary health setting. You have to go to the level 3 hospitals in towns and urban settings by traveling 5 to 15 kilometers. So if you think of a poorer person and an older person who doesn't work. They're predominantly rural, so agriculture dependent. So they don't really have formal pension system. How can they support their diabetes management and living, with less burden of disease and less reduced mortality? So 700,000 people in 2021 were diagnosed with diabetes in Uganda. And there's still, from our study, 36% of undiagnosed diabetes, which is exceptionally high. So we are constantly pushing this boundary, constantly looking for various sources of funding. We have developed a strong team from 2017. No matter what the funding is, we sit together every week and we say, what is that we can do with the resources we have, with the talent we have? So we keep marching all the time. And then we managed to use low cost kind of settings of, working with the government, working with different stakeholders, and managed to get these really nice ways of showing that we can use village health teams that are already there in villages to reduce the burden on hospitals and then reduce also screening kind of undiagnosed diabetes so that people can go early on for care and reduce the diabetes mortality. So we'll keep pushing the boundaries. And the ultimate aim we have for these rural settings is that we work with the cooperatives very closely and think of $1 a year scheme where every member in the village will give to the cooperative $1, and then we purchase bulk medications from the pharmaceutical companies to reduce, so that it's independently run on their own with the companies where we researchers facilitate what is that they need. So at the moment, we are just carrying out focus group interviews to understand. So we could show it's feasible to employ village health teams. Now we want to understand from the people living in villages, would you like them to be supporting you for health-related communication? So if they say yes, our next step is do costing analysis and carry out more advanced kind of work so that we can push policy towards this sustainable primary health setting kind of work. So yeah.
Thank you, Aravinda. And I think the next question I'm seeing sort of posted actually follows on quite nicely from what you've just been discussing. So I think I'll bring Aravinda in again for this one. Are the trends of specific social factors impacting public health in Aberdeen and the UK, which we were hearing about sort of particularly from Shantini and Sarah, but from Catherine as well, also being seen globally? And what can we do to address these in our communities?
Yeah. So the universal health coverage is supposed to take care of lots of health conditions and issues in multiple settings. Unlike UK, where universal health coverage covers diabetes and various other non-communicable diseases, it doesn't really work in low and middle income settings. There are a variety of reasons for it, one being the funding. So who provides the funding? So some of the funding comes from the WHO core funding as members pay based on their income level, GNP and population. So that goes into some of those activities. But increasingly, donor-driven funding focuses on certain type of topic. For example, Bill Gates Foundation might give and say, I might want to focus only on this funding in Uganda and Tanzania on HIV or family planning. So you have funding in such a way that the donors decide the topic. So for example, in the case of Uganda, the same setting we discussed before, 95% of the cost for HIV treatment and care is covered by the government because the funders are able to provide for HIV related, but not for diabetes related. So we do have these kind of inequalities between countries and within countries as well, which is very different. But we are in a very complex world that the global health funding is declining and the challenges are increasing. So we are heading into a place where economic crisis is going on, climate crisis is going on, health systems are very weak, and lots of challenges. Governments are shifting that are cutting down global health funding. So we are in a very, very complex, bumpy environment. So, but we just have to carry on pushing forward the agenda that health for all and no one should be left behind, irrespective of income.
Thank you, Aravinda. And I think actually I'll bring all the panel in for the next question because it's about which policies do the panel believe have been most successful in addressing these social issues, and can they be adapted by different governments in different parts of the world? Shantini, maybe I'll come to you first on this question.
Yeah, so I think it's a really good question. I don't think it's a one policy fits all type answer. And so I think probably my starting point to answering that is to draw on some of the work that the Institute of Health Equity and Professor Sir Marmot has done, outlining the 8 areas for action to reduce health inequity. And I think these apply whatever country you're in, really. And so the fundamental thing is giving every child the best start in life. There's so much evidence now that actually if you get the peri-conceptual, the time in during pregnancy, a lot of our development, everything starts then. So actually a time during pregnancy in the first 5 years of life, getting the environmental conditions right, the social conditions, and giving children the best support to develop and thrive probably, will make the most difference throughout the life course. So giving every child the best start in life is probably one fundamental one to start with. And then enabling children, young people and adults to maximize their capabilities and have control of their lives. And then, creating the conditions that will provide the building blocks for good health. So creating fair employment and good work for everyone, ensuring a healthy standard of living, and then where we live is important as well. So creating healthy, sustainable places, strengthening the role and the impact of prevention, and really, thinking about prevention in all our policies is probably a good place to start as well. And then tackling racism, discrimination, and looking at our environment and climate and policies in place to ensure environmental sustainability. So I think that's a good starter, but I'm sure others will chip in as well.
Yes, so Catherine, would you have anything else to add to what Shantini? That was quite a comprehensive coverage, I would say, by Shantini.
I don't think that I could have answered that any better than what Shantini said, actually. So yeah, I think it's a complex question that was asked. So whoever posed that is really thinking, and I like that. I think it's going to really focus in on what are the area, in a particular geographic area, what are the issues, where are the funds and the resources, what are the priorities, and the politics. I think a lot of it comes down to is, what is it that people are feeling passionate about in terms of making policy changes. So yeah, I'll leave it there.
Sarah, anything else to add on this question?
Just to concur with Catherine, it's a complex question and therefore needs complex solutions, I suppose. And I think for me, one of the main things is to try to break down silos and create better opportunities to work together and pool these constrained resources, constrained resource time that we happen to be in for public organisations. No mean feat, however, very challenging indeed. So I think it's good to have the outline that Shantini gave there of those kind of building blocks. And I think the next step is to try to figure out better ways of working together to try to achieve them.
And thank you, Sarah. And Aravinda, anything you'd like to add?
I think from a policy side, everyone has covered, but from global health perspective, just want to bring the attention to the Millennium Development Goals and Sustainable Development Goals that played a very important role in fighting some of the challenges. So at the start of the millennium, 189 countries for the first time came together and agreed to focus on 8 different goals. And the goal first was eradicate extreme poverty and hunger. And the target date was 2015. And there were there were 7 other things, including primary education, maternal mortality, global partnership. Because there were specific goals, we were able to reduce the extreme poverty by 50% by 2015. And then building on that, we created 17 sustainable goals. And these sustainable development goals are meant for everyone, high or low income country, because the previous one very much focused on low income settings. And the aim is no one should be left behind. Somebody in Aberdeen is poor should not be left behind. Somebody rural area in Aberdeenshire should not be left behind. Somebody Uganda, India, anywhere, it doesn't matter. No one should be left behind. And I think that political shift is very important, because once you have that political shift in the mind that nobody should be left behind and our health, the life expectancy and life and everything should not depend on the monetary basis that we have, I think that's a good shift. So I think even though sustainable development goals are not working the way they should work because of the COVID-19 pandemic and all the chaos, political and other types of chaos as we witnessed in the last years, it's good to have very specific targets and goals that we want to achieve. And that's what I want to add to everyone. Everyone covered everything on policies. Just want to add the global side of the policy.
Thank you very much. I'm sort of just keeping an eye on time here, and I know that we are getting a bit short of time, and I'm seeing lots of questions that we've got put in the Q&A, so we may not have time to address them all. In fact, we probably won't have time to address them all in this session, but we will sort of address them afterwards if we don't get time to address them in the session. So I'm just going to actually jump to a question further up about what advice would you give an early career public health practitioner or researcher sort of coming into, I guess, this area, if our students are thinking, you know, about when they complete, for example. Catherine, I'll start with you on this.
Yeah, that's a fantastic question as well. I think so. So for me, I had a quite traditional, boring, if you will, sort of background where I've gone from, you know, my undergraduate, my master's, my PhD, postdoc, and come all along. So I've been very much sort of in the academic mindset for a very long time, and I think I've been sort of pondering quite a lot of different things over the years of, you know, when we have different types of students come in and they're asking these sorts of questions. I think I've always seen, even though it looks like a very linear trajectory, in my mind, I've been open and quite flexible with what it is that I'm interested in learning about. And so while one thing sort of piques your interest and you focus on learning and pouring yourself into that, and when the next opportunity comes up, if it also piques your interest, there's somehow this flow and I guess the idea of going with what you're really interested in and what you're passionate about learning about, because that's what makes it fun and worthwhile. Whereas years ago, I guess people would say, well, what's the next big thing, do you think? Because you're coming off of all this big tobacco money back in the United States. I was in my PhD and there've been lots of money poured into researching and looking into that. What's the next big thing? What are funders looking for? And I think it in a research sense, it's trying to stay away from that, but building yourself and growing and having the flexibility to do what it is that you're interested in researching, and getting involved in the community wherever you are some of the advices I might give. And
Sarah, what about yourself? What advice would you give?
Oh gosh, it's a great question, and it's actually not that easy to answer. But I suppose, well, I certainly haven't had a linear career path at all, and I've jumped from discipline to discipline, and not because I couldn't make my mind up, or maybe it was, who knows. But I think it was very much in that vein that Catherine's touched on there. I think it's because I was interested in different things, and when I look back over the time, there are similarities between it, but a lot of it wasn't necessarily because, oh, I must stick in this field. It was because I was attracted to certain things that had something that spoke to me, I suppose, at the time. So I started off psychology. I was really interested in you know, behaviour, and then I thought, well, what about the wider context? Where is that here? I'm kind of not getting that. And then what about doing research that's actually practical? I would like to do something that actually makes some sort of difference quickly. And then I meandered around applied social research, and then geography was quite a nice home for me because it was very broad. And I think maybe the piece of advice I would give is certainly read widely. I mean, if nothing else, the degrees that I've done has forced me to read across a lot of different disciplines, and that led to public health as well. Not necessarily directly, but a lot of the work in geography, I was interested in health, and of course I was reading around public health. And then another thing too is maybe see if you can try to work with people that you admire or that will teach you something. From all that reading, there was lots of names that came up, and their work I really admired a lot of work from a lot of the people that I was reading, and then that led to other things and to other contacts and to broadening that kind of sphere of understanding and knowledge. So I feel that that's my main take home. Don't be stuck in necessarily within one thing. Keep your mind, keep open-minded, and then try to work with people that you admire and who you will be able to learn something from as well. So I think that that's good advice. I wish someone had told me that, but they didn't. I just found it out for myself. So there you go.
Thank you, Sarah. And Aravinda, what about yourself?
Yeah, I think this is, as both Catherine and Sarah said, very tricky question, but they touched on passion and reading widely, and I don't want to repeat this. Totally agree with global health work also. If you're not passionate, there's nothing you can do because you'll have so many barriers. First of all, for you to get incidence of diabetes in Uganda is so very hard from 40 hospitals creating all the databases, and you submit to a journal and journal will think, oh, every country has incidence of diabetes, so it's nothing new. So just carry on. So what is big for us, big deal in the low income setting, many people might not understand it's a big deal. How we reach to that step, going through so many barriers is a big thing. But what keeps us marching every time is we are so passionate. We want to ensure that we increase the database, we show the visibility, we show the inequalities, we do field work, we are multidisciplinary. So I would say, yes, passion is important, reading widely is important, but also the evidence base, what is there, where is the evidence, and then start building on the evidence it doesn't exist and make partnerships with people. So our team always meets every Tuesday. We have been meeting for 3-4 years every Tuesday. Very rarely we disconnect. Sometimes we talk for 10 minutes, but we talk. We are like, what is that next agenda we want to do? What is that we have to carry on? Which paper we have submitted? So it's just having a common agenda, group of people, no matter what, carry and push the boundary every step at time. Sometimes tiny steps, you go backwards, you go forwards, but keep marching, and that would help, especially those coming from low income settings. Don't be disheartened if you don't get funding straight away, if people don't think your topic is specific enough because it has been covered globally. Your passion and the thought that you want to make difference to those settings is still novel. So keep pushing on that ground.
Thank you, Aravinda. And Shantini.
Yeah, I don't know that there's much to add to that, but so I actually think the key thing to public health is getting your foundations right. So there are some basic skills that you should invest in, and be clear and really so because that is your toolkit, and so as you have gathered, public health is quite a broad specialty, but the key thing is, get your foundations right. So you've got your toolkit, and with that you can work across. You can apply that then across a lot of areas in public health, whether it's non-communicable diseases, communicable diseases, or health intelligence policy. You've got to have your toolkit of skills and techniques really that you can apply. And I guess the most exciting thing about public health is probably its breadth. And as you've gathered as well, it takes there is no just one public health specialist. We come from different backgrounds, and that's what's good about it, and that adds to the richness around it. So I think one of the good things about public health is that you learn something new every day, and you do that because you're working with different people. I still learn something new every day, and I suppose that's one of the most exciting things about it. So I think what advice would I give you? I'd say, get strong foundations, and then just go out and enjoy it, apply it wherever wherever your interests are, and just enjoy the journey. I think that's the other thing about public health. It is a journey, and it is a learning journey really for all of us.
Thank you all very much for that great advice, I would say. Unfortunately, we are running out of time. I think we could have sort of had another hour talking about this, and certainly seeing all the questions that are being posted that we've not been able to address, unfortunately, during the time. And as I say, we will try and endeavour to address these sort of offline afterwards. You know, we certainly could have discussed this topic a lot longer. So I really want to thank all our panelists today, all our speakers today. You know, I think they've addressed these questions very well, and as they've given some great advice for future people in the area of who want to work in global health, public health, or related areas. And as I think some of the speakers mentioned, you know, during your time with us, if you do choose to study some of these topics with us, you would have opportunities in work-based placements and research projects, you know, related to these areas. What I want to finish off is it's an exciting time for us with our public health and global health programs, because we have just received our curriculum validation from the Agency for Public Health Education and Accreditation, which is our first step in achieving full accreditation for our programs in this area. So it's a very exciting time for us with our programs in this area. So thank you very much for joining us today. Thank you again to our panelists, and hope you have a good day. Thank you for now.
Bye.
Thank you.
Bye, everybody.